Welcome to the RCM Ladder. We dive into career development and growth for revenue cycle professionals, helping you level up your career one episode at a time. This episode of the RCM Ladder is brought to you by our good friends at the Health Exchange. They are building an awesome community of revenue cycle professionals with the knowledge, insights, and resources needed to navigate the ever-changing landscape of healthcare reimbursement. The team at the Health Exchange have awesome content and events tackling everything from denials management to revenue integrity, patient access, and the importance of leveraging RPA or AI in your operations. The content is so useful, so smart, so impressive, so collaborative. Honestly, it makes us jealous. So go check them out now, right now, and then come back to us. You can find them at healthexchange.io. That's HEALTHXCHANGE.io. And now on to this week's discussion. Hey everybody, welcome back to this week's episode of the RCM Ladder. As always, I'm your host, James Furbush, and my guest this week, the one and only Katina Robinson, who is a patient access manager for Methodist Hospital for Surgery in the Dallas, Texas area. Katina, thanks so much for joining the show this week.
James, thank you so much for having me.
Yeah, so Katina, give who are you, what are you up to, and a little bit about Methodist Hospital for Surgery. What kind of a fraud organization is it?
Absolutely. Methodist Hospital for Surgery is an affiliate of, big Methodist, as we say, Methodist Health System. And we're a boutique hospital. So we, 32-bed hospital, like I said, very boutique hospital. We specialize in surgery, a lot of orthopedic surgery. We do other surgery, do some cardiac surgery, some neurosurgery, but orthopedic surgery is kind of the bread and butter there. So great little place to come to have some surgery that needs to be done. Great care, specialized care, because we are a small hospital. So, the nurse to patient ratio is very small. So you get a lot of personalized, specialized care at Methodist Hospital for Surgery. I've been in healthcare management 10 years now. Definitely wasn't expecting to make it a career when I got in, but I absolutely love it. Started in South Georgia, where I'm from. Now I'm here in the Metroplex living in Dallas. My career has taken some twists and turns up the RCM ladder, so to speak. And, just very excited for where I am and where, I plan to be in the next couple of years.
Well, let's get into those twists and turns. You said you were not expecting to stay in healthcare, but you've been in it now for over decades. When you look back at that past 10 years or 12 years, why did you not think you would stay in healthcare?
Well, I will tell you, when I, left high school, was in college, I have a lot of families in healthcare or they're educators. And the things I said, I never wanted to be a teacher and I didn't want to be in healthcare. And I never thought of rev cycle as a side of healthcare. I didn't know the rev cycle side before I got into it. So it was mostly clinical. I don't want to be a nurse. I don't want to be a doctor. I don't want to do that. And when I got in and I started an ED registration, and oh my gosh, fell in love. I fell in love with the organized chaos in emergency departments. It's a lot of chaos. It's a lot of moving parts. Nothing slows down in the ED. You don't want to say quiet or slow because then the floodgates opens. And I really fell in love with the rat race, so to speak, that is ER registration. You're always moving. You're never sitting. And I said, oh, I like this. That first year, I got a certification through HSMA. I got my CPAR. I don't have a CSC anymore, but I got my CPAR, my certified patient access rep. And I was like, oh, this is different. And I learned a lot of insurance. And I never thought I would like insurance the way I do. And it makes sense to me. I realized that it made sense to me. I started to say, you know what? I am actually really good at this. I can see a future staying with health insurance, staying in the hospital system, staying in access or hospital. I strategically started to make it my career.
That's incredible. You've worked for a wide range of organizations, right? So you're working for this boutique hospital now. Obviously, it's part of a larger Methodist system, HCA, another big kind of system, and also regional health systems as well. When you think about your career, what are some of the skills that you've developed and leaned on to advance your career?
Um, Active listening and effective communication were one of the first things that I really, really worked on and started to develop. Even when you're in ED registration as a frontline staff, your patients are constantly talking to you and telling you things. Some of those things are very pertinent, maybe not for you and what you're doing, but the nurses may need to know, the doctors may need to know. I developed that skill of, okay, let me listen to the patient, let me filter the things I need, let me put into this corner of my mind what needs to go back to the nurse as soon as I'm done. Let me find the nurse or call that nurse or physician. They may go, oh my God, this is going to be crazy. I'm going to be out of work for so long. Or now they tell me I have to go for emergency surgery and they're worried about how they'll pay for their bill. And what I'm hearing is they may need financial assistance. They may need a financial counselor to come talk to you. Hey, you may want to go check on the patient room. Effectively listening to the patient and what their needs are has been very helpful. And I'm a self-starter. When I see there's a gap somewhere, I like to fill that gap. And in doing that has allowed me to take on projects. Since you're already doing this, here's a project. I kind of volunteered myself for several different things. Being a self-starter, I've learned different skills while doing that, whether it's a report. Now I know how to look at charges, whether it's a report, and now I know how to differentiate that charges are on an incorrect account and I can fix it. Now I position myself as a go-to person where, hey, this is wrong. And Katina knows how to fix that. She fixed the other ones. Let me go to her. And so I can be a resource to people, not just in my department. Now I'm a resource to the rest of the rev cycle for our patient financial counselors. Now I'm a resource to our surgical services because Katina knows this is on the wrong account and she knows how to fix it, or this is stuck. Katina can trick the system and can get us what we need, where we can put this patient in putting myself in those positions to learn those new skills, those reporting, those charges, what those things mean has definitely helped me to advance my career.
How do you balance, sorry, excuse me. How do you balance the, because you said like, okay, I've learned how to be a good listener, having sort of bring that sort of can do, just jump in and do it attitude versus the sort of more tactical, I need to know how to do certain reports or work with certain systems and things
Mhm.
like that. How do you balance those? Are they conflicting at all? Or, are one more important than the other for you? Or how do you sort of
Sometimes they
think about?
are. Sometimes they are. And a very smart person once told me just because you can doesn't mean you should. So just because I learned the report doesn't mean I actually have to do it. Sometimes someone can come to me and say, hey, Katina, I know you know how to. Can you help me out? And I say, I do. However, that's out of the scope of my job. So I'm going to redirect you to person X to work on. So I can continue focusing on the things I need. I always make sure those things in your scope, those things that are in your wheelhouse are taken care of first. And you can always build new skills on top of that to stay focused on these other reports I need to know. Or, hey, here's a gap. I think we need a report for this. And I know that this report that Patient Financials has, we can kind of pull that report and tweak it and use it for what we need. So it's been beneficial to maybe use some of those other things in the avenue of patient access front end rev cycle, so to speak, that you may pull from another area. But I always remember just because you can doesn't mean you should. I may have all of these skills that I can lean on and I'll pull them out of my toolkit when I need to. But if I don't, they're just kind of sitting there waiting to be used.
Yeah, that's awesome. I want to jump back to something you said at the start, which is sort of falling in love with this organized chaos in registration. Was that surprising to you? What is something that has surprised you as you think about where you started your career to where you are now about working in revenue cycle?
So one of the things that surprised me, really took me aback is when I started in South Georgia, my lovely hospital, my hometown hospital. I knew a lot of people who worked there. I mean, it's the biggest employer in the county. It's bigger than the school system. So it's the biggest employer in the county. And so I know a lot of people who work there have family and friends. When I started and they saw me in orientation and then just starting around, I heard a lot when asked, where do you work? I said, oh, I'm in ED registration, or oh, I'm in patient access, with this wonderful enthusiasm. And they just kind of look at me and go, are you sure? And it was such a negative perception of rev cycle and of patient access. And it has been. And I found that in multiple places where I've been, the front end is always messing up. What really surprised me was that perception that others outside of rev cycle have. And I'm here in the thick of it. I know the hard work the team does. I know the long hours the team puts in. They are just as dedicated and invested in their patients as the bedside nurse is. If one mistake that is made, if there's one, digit that's left off of an insurance number and we get a denial from the payer because they can't find the patient access is always messing up. That just really threw me for a loop in the thick of it. They're not in the weeds of it. They don't truly understand what patient access does. I have made it my charge for others to see us in a better light because we work just as hard as anyone else. We are bedside in ED. We hold hands with family members who have dying family members. We are right there. And with, unfortunately, with that nurse, I've seen it a lot. They do the same thing. They sit next to that patient caregiver and they're holding hands and they're empathetic. And with patient access, we all have difficult jobs, and not to diminish what nurses do. My mom's a nurse for 42 years. I love our healthcare provider. Patient access, we are sitting right next to that family member. And before we can even ask name and date of birth or verify information, they are already upset. They don't know what's going on. They are so scared. Their family members are so scared. And we still have to ask for insurance. That's a tough part about what we do that I think people don't realize. We still have to ask for that insurance. We have to walk that fine line of, do I ask for this payment now? Do I ask for this payment when they're discharged? Or, hey, this person is dying. They're transitioning. Let me get the information I need. And that's a very hard thing to do in some of these situations. That negative perception some organizations have of patient access really surprised me when I started because I wasn't expecting.
So I have two immediate thoughts. One, and then I'll jump to my second thought as a result of hearing that. So you said that's really hard, and it is. Asking someone for their insurance, oh, by the way, I know you're dying, but please can I get your insurance card? That's an awkward and horrible conversation to
Really
certainly kind of navigate. What is then the hardest thing about working in revenue cycle or even patient access? Is it that, or is there something that you have found is even harder than that?
That is one of the hardest pieces, showing empathy and professionalism while still getting what you need from your patient or caregiver. I've been in situations where there's been a tiny baby on the table that the clinical team is trying to stabilize, going downhill very quickly. And they are trying to transfer this baby out. The receiving, hospital is needing a face sheet with insurance. But I'm the person in the room and that mama's squeezing my hand and I have to get insurance so we can better take care of her baby. That conversation is very difficult and training helps with that conversation. Another thing probably equally as difficult is the ever-changing payer guidelines. The payer guidelines change mid-month, midstream. You find out 6 weeks later that, United Healthcare has changed their mind on some things that did not require all 2 weeks ago, and they do today. The ever-changing payer guidelines make it very difficult to continue doing what we do, especially when it comes to authorizations, especially when it comes to benefits, things that are covered versus things that are no longer covered. And, this CPT code may be covered and that one isn't. And translating that to your patient or your customer. Customer may be physicians. I remember standing in a room full of physicians and several leaders, and we're having the conversation because payers changed guidelines at one point. This was several years ago, but they changed guidelines and said, we're not going to pay for MRI unless that patient's had a CT first. As a physician, you're telling me that I got to order a test that the patient doesn't need. I know they need an MRI, but the insurance isn't going to cover the MRI. We're like, this is what they're saying. Here's the guidelines. We've met with the rep. We're telling you what they're saying because we know this is going to be difficult. And the physicians being livid because, of course, they're thinking, you're going to put my patient through a test that I know is not going to show me what I need. The test that I need isn't going to be approved unless they have this test first. And we're looking at them saying, that is exactly what we're doing. That is, when did that change? Well, that just rolled out last week. When did y'all find out? We just found out yesterday. And that's what we're having a meeting today.
Yeah, that's sort of a constant tension within a revenue cycle. Back to what you're talking about, perception of a revenue cycle within a provider organization, within a care setting, that you guys are as much a part of that, delivering sort of that care. It made me think, I'm sort of listening to this book right now called Unreasonable Hospitality by, I forget the author's name, Will Goddard or something. But anyways, he talks about in the restaurant industry, it's sort of almost like that same dynamic of like the chefs or the doctors and look down on the front of the house staff. And, to carry the analogy, you guys are kind of revenue cycle would be sort of that front of the house. But to have a successful restaurant, it's not just about the food. It's about how the front of the house makes people feel when they come into the restaurant. They get seated to the table, when the food is delivered, like all the thousands of little things that the front of the house does to deliver hospitality to guests. Anyways, you sort of just made me think about that a little bit.
I think when it comes to patient experience, because at one point I was a trainer, and one analogy that I always try to use is when you buy a case of water and you get home and you got to pull it out your trunk or your back seat, and you see there's some wetness somewhere, and you've got a case, something's leaking somewhere in your case of water, and you return it back to the store. You don't return the one water bottle that's leaking. You return the whole case. And so from a patient perspective, they look at the whole case of water. They don't just look at that one water bottle. They say, hey, I had a great experience or I had a poor experience. If the front of the house, so to speak, if that first encounter from the time you were scheduled for your surgery or service all the way through your registration, you got your insurance authorization pretty quick, and you were able to get to your test, and the techs were great, and your doctor was great, and everything's great. But if something drops the ball, especially in the beginning of that process, you can almost assure that in the patient's mind, they're already cautious about the next, who's going to take care of them. Are they going to be good? Because these people messed up with my registration. They didn't tell me this about my insurance. They didn't tell me that it was $350 before I got here. And now it's sticker shock. It messes up the rest of the visit. That front of house, that patient access, patient experience, and interaction there has to be really good. If we had a little more support and kind of managing up from our peers and colleagues in other departments, that would go a long way to help with
that. Yeah, that's you for that. Yeah, it's amazing. It takes everyone rowing in the same direction. For you, let's change gears a little bit. Do you have a vision? Now you've been in healthcare for 10, 12 years. You're thinking about maybe the next 10, 12 years, maybe 10, 12 years after that. But you sort of have a vision for now where you want your career to go? Do you think you're going to stay in healthcare for the long haul? Do you think you want to stay in patient access and revenue cycle? What are you thinking about that next evolution of your career and where you want it to go?
Right. So I love patient access. I always said once I got to a certain place, I never want to leave. This is the sweet spot. I love training. When I had the opportunity to be the trainer in South Georgia, I loved it. It was that aha moment. Training really is my wheelhouse. I love it. It's data analytics. And so, I'm really looking the next 3 to 5 years. I would love to be in a training manager role or doing some data analytics. Those two, sometimes they go hand in hand. When you train for patient access, you have to know the data behind it. I love both of those things. Reports make me happy. I definitely want to move in that direction.
What is it about training for you personally? What is it about training other people?
When I trained, I had my own catchphrase, my own vision statement, and that was to create well-informed staff to help create well-informed patients. The more informed your staff are, they can help your patients understand and be more educated about their insurance, their deductible, all of those things. Seeing that aha moment when I was training and someone's like, oh, I get it, Katina, that's why we can't do X, Y, and Z. I have so many, times where I've trained and it could be a month or two or even further down the road. One of the staff members I trained would call and go, oh, so I remember in training, I had someone call me from an oncology building And she said, I remember in training, Katina, you said patient could not have Medicare Advantage plan and a Medicare supplement secondary. And I said, you're absolutely correct. You can't have a Medicare Advantage and a Medicare supplement secondary. Because this patient has Medicare Advantage plan and ARP supplement. And I told her that she could. And she says, yes, I can. And I tried to explain why. And she said she's been paying for ARP since 1984. I know this conversation. The patient was very upset. She was very happy that we told her this because at the beginning of the year, she had changed from traditional Medicare to a Medicare Advantage plan. It was her first time having a Medicare Advantage plan. And this was one of her first visits. No claims had gone out to ARP secondary yet. But she was paying her premium. I said, as soon as the ARP gets that claim, they're going to kick back and say, we're not going to pay this. And then she's going to have a different conversation like, well, I've been paying my premium. And so I said, just go ahead and call. The patient was so thankful. She talked ARP. She ended up got a refund for her premium that she'd been paying because she'd been paying her premium for something that she could not use. And she wasn't aware. It wasn't until my staff member was in that training. She told me, because I didn't know that until I came to your training. And so we helped that patient out. And it's things like that why I love training. My staff and whoever I train can empower a patient and maybe tell a patient something they didn't know to help them with their health insurance. And that's very important.
It's interesting to hear you say that because at the outset, you talked about you either almost went into education or healthcare. You don't want to go into education, but it sounds like you sort of went into
I've done them both,
teaching
right?
healthcare.
I think it's so funny because those are the things I did not want to do. And I find those are the things that I love doing. I end up doing them anyway.
Oh, that's amazing. When you find something you love doing, you have to lean into that because it just makes it so important to that enjoyment of your job and, kind of showing up for the 8-10 hours or whatever it is that you're putting in on a daily basis. So for you, are there certain things that you're working on professionally to become a better trainer and a better data analytics person to sort of set yourself up for kind of that next stage of your career?
Yes, absolutely. In my current role, we have a trainer specifically for our department, which is great. So we have our corporate trainers, and this person's been certified and is our kind of own trainer, kind of the role that I used to have. I work very closely with him and his manager and say, hey, these are some things that I think would be great, and almost mentor him a little bit in his new role as a trainer. And that has been very helpful. And it allows me to stay on the thumb of that mass corporate training. I'm always doing impromptu ad hoc training. Currently, I have 7 clinics that I manage. And so, I was at one yesterday and was doing some training kind of ad hoc there. And I love to step in and do that. Working with the reports team and building new reports and seeing where we don't have reports in place on things that we need to look at. I'm fairly new to Methodist Hospital for surgery. And in this role, and my role that I'm in is a brand new role that I haven't had before. And so as I stepped into it, I immediately said, hey, what reporting do we have? My director told me the reporting that we currently have. She asked, what kind of reporting are you needing? I said, I need reports for, and I started rattling off about 3 or 4 different things. And so she goes, oh, I don't think we have that. And I said, we need to look at that. Who do I need to get to? She's like, get with the reporting team. And so working with the reporting team on learning how to build reports. And they're showing me, hey, you can build reports by doing X, Y, and Z. And showing me those skills and how I can do that in the EMR that we are in so that I can tweak and build my own reports. I love to build and see what we need so that I can look at that data and translate it not just to my boss and the C-suite, but to my staff. They can see the progress they're making, or, hey, this is where we're falling short. This is why we have to do MSPs correctly because this is where it's affecting. Working closely with those who do those things every day and working on them myself, being able to pull and build reports myself is really going to help get me to that data analytics piece.
Nice. This is a good segue because we're going to do the lightning round. This is the new thing we're trying out here. And since you're talking about data analytics, all right, so the lightning round, here's how it works. I ask you a quick question. You give me the best answer. Don't put too much thought into it. And you just kind of first answer is the best answer. All right, you ready?
Yes.
First question, speaking of reports, what's the most important metric for you and your team that gives you the most anxiety?
Oh, there's always preventable denials, always at the top of my list. Secondary to that, patient collection. Are we collecting what we should collect? Gives me anxiety every time. I actually talked with someone yesterday, and it's like, well, we need to look at collections. Looks like we're doing good. We collected $155,000 last month. I said, well, how much should we collect it? $155,000 don't look good. We should have collected 600.
It's
Like,
good.
what should we have collected? I said, we need to create a report to see how much we left on the table.
150,000 to 600,000 is not a good
That's right.
percentage. I don't think.
That's right.
All right. Question 2. What's your biggest goal you want to achieve, or you and your team, for 2024 or this year?
My team is a new team. Solidifying them as a team is my number one goal. They are 7 clinics that have worked independently of each other, very siloed, not much engagement, and I've been building them as a team. That takes some time. So solidifying them as a team is the number one thing for 2024. We're working on, metrics. They're all doing things well and not so well, but they're not the same thing. Getting them as a team and using each other as resources, I think is going to be even better for those things we're trying to work on.
What is something you wish people would talk more about when it comes to revenue cycle in healthcare?
The work that we are doing, how hard the team is working to get your organization paid. Oftentimes your rev cycle teams are using multiple systems to make this happen. God forbid you would have just changed EMRs. There's a whole legacy system, and there's bills in that legacy system that are not zero yet. So give us some grace. We are unsung heroes. We're still trying to get us paid.
And finally, what is your professional superpower?
Love that one. Okay. So I would say I'm very good explaining concepts and ideas to where it's digestible to anybody, whether it's the C-suiter or the frontline staff member, so that I get a buy-in from everybody, even those who are kind of holdout and those naysayers. I get their buy-in so that we can move forward with a project or a concept. It can be very difficult to do that, especially when it's large teams and large amounts of people. I do really well with.
Love that. That's awesome. Back to being an educator, right? And then finally, part 3, this is really just your chance to talk about Methodist Hospital for Surgery. Are you guys hiring? Do you have open roles? Where can people go to learn more about any job openings you might be trying to fill right?
I manage 7 physical therapy clinics for Methodist Hospital for Surgery, and we do have some openings. Absolutely. We have an opening in Denton, Texas, and we have 2 openings in Plano. And we have 2 locations in Plano that we are hiring for. And we absolutely can use some great experienced patient access specialists, whether it's hospital system, whether you've worked at, doctor's offices before. The team does scheduling, registration, insurance verification, insurance authorization. So we do all of the, and financial counseling. And so we're looking for some good experienced individuals who want to join our team with me as their manager, the captain of the ship, so to speak. We have a lot of great team members, and I definitely want to add some great people to our team to help push us forward in our new venture.
Wow, that's great. And finally, Katina, if other revenue cycle people were listening and they want to connect with you, what's the best way to get in touch with you? LinkedIn, TikTok?
LinkedIn. I love LinkedIn. I love LinkedIn so much. You can find me on LinkedIn with my name, Katina Robinson. It's a nice little picture of me there. I engage a lot. I am an engager. So, if you want to connect with me, get with me on LinkedIn, and we'll absolutely touch base and connect.
All right. Well, Katina, thanks so much for spending some time with us talking about your career. Really appreciate it. You have been a wonderful guest, as I expected you would. So thanks so much for stopping by and talking with us today.
James, thank you so much for having me.